Hello, everybody.
Hello.
Hello.
Sorry about that, LJ. We're having some issues on my end getting the meeting going. But
No, I thought it was just me, and then Chad said he wasn't ghosting us, and I said I'm not either. So it's all good.
okay. All right, looks like we have everyone and I'm recording, so ready to go when you are, Chad.
All right. So welcome back, everybody. Sorry for folks for hanging out in the waiting room with us. We were experiencing technical difficulties, but we're all good now. So I guess bad news, good news, take it for whatever news it is. There's not a whole lot new in the world of COVID to talk about today from the last time we talked. So that's good. Unfortunately, we are seeing pretty much across the entire Finger Lakes area an uptick in COVID cases. We are starting to see more exposure. And with that, several folks have reached out with varying questions, all that center around the same concept of, oh my God, patients and in some cases staff are starting to come in and either they're coming in with symptoms and they're not announcing themselves, or they're not masking appropriately, or they were staff, but they went on vacation and they came back and they weren't wearing KN95s or N95s, and they were just wearing surgical masks, but they were still within their 10-day window. Or patients were supposed to be under quarantine. They came in for foot fungus and they didn't tell anybody until after the fact that they tested positive. And by accident, practices found out about it. So there's a myriad of those kind of things where everyone is not being as full disclosure or even fully attentive to behaving in the way that we may all wish that they would. So the easy answer is we have no recourse whatsoever. Almost by the day, it's no secret to anybody that the absolute requirements are being unwound. For better or for worse, we're moving to a realm where if you look across the board, the number of people who are dying from COVID is dramatically less. That is absolutely true. Are we still having a good number of people getting infected with COVID? That is absolutely true. At this moment, would the mortality statistics say that you are more likely to die from flu than you are COVID? Yes, that is true. So, in that frame, I think this is not different than what we've probably dealt with for 100 years, where people didn't walk into the practice wearing masks and declaring themselves to be actively sick, and they just kind of licked everything. And, whether that was staff or patient, this has been kind of background noise for us for a long time. I do think, and several have asked on the contrary of, hey, everyone else is kind of unwinding masking requirements. What do we do in common areas? What do we do in, break rooms and practice, that kind of thing? My general reflex has been, you could probably make a good argument, given that we all should be masking in patient care areas, that probably the masking is the best thing that we can do, because we can't be assured that the person on the other side of the table is actually doing exactly what they should be doing, given their current circumstances in the world. That's an imperfect answer, and I realize that's a very kind of Pollyanna kind of approach to it. And I'll be the first one to say, do I want to walk around with a mask stapled to my face for the rest of my life? No, I don't really want to do that. However, I think that if we're asking the question and concerned, I think this is happening far more often than we're probably even aware of at this point. I know from testimonials from a million people that, I was supposed to be quarantined, but, I went out to Walmart anyway because I was stir crazy on day 7. Okay, great. You shouldn't be doing that. It's happening a lot, and it's probably people that we're rubbing elbows with in Tim Hortons to get coffee, or Walmart, or wherever the case may be. So I think you pretty much just have to accept that, unfortunately, that is the world in which we live, and people are just tired of COVID now. And, on the positive side, I think it is a different disease. Now, are people dying of COVID? They absolutely are. So I'm not trying to minimize it by any stretch of the imagination, but fortunately, because of everything that we have done successfully up until this point, it may not even be the most concerning thing in the community right now from a viral transmission at the moment. So I do think that frame of reference probably is as important as anything, because we're not going to be able to get the masses to go back to where we were. I think that cat is kind of out of the bag, and we are where we are now. I realize it doesn't make anybody feel warmer and fuzzier. It doesn't decrease the consternation, and there's still enough of yep, there you go. We're out of business for 5 days. That's exactly right. You got it. That is the moral of the story. Bob said it better than anybody. And if you haven't gotten it, it's probably just a matter of when, not even a matter of if at this point. So I say all that to say, the good news is, from a presence, it is probably even more present in the community than what we knew, or what we were experiencing certainly a few weeks ago. Are we seeing a major shift in strain or anything? No, I think we're pretty much in about the same spot we were the last time we had the conversation. Are we starting to see more flu? Yes. Have we had a major outbreak of flu in the area? Not that I'm aware of, but maybe I'm a little bit behind the game on that one so far. Do we anticipate we're going to have a big outbreak of flu? Yeah, I think that would be a safe bet for this year. And so far, if we take the Southern Hemisphere as a guide, the flu risk is probably going to be higher for the same high-risk populations that COVID is. And maybe we've got a little bit more protection from COVID right now than we even do flu, or at least the strain that's going to be prevalent. So take that as good news, bad news. I don't know if it's just news. Maybe it's not even news. And I realize it's not a great answer, but people posed a lot of different variations of questions around that, as I alluded to. And it's not even that my answers are kind of half-hearted. It's just that the reality is there's not much we're going to be able to do except try to mask ourselves as best we can, and understand that if we say, gosh, that's really a pain in the butt and people are not going to do it, then yep, there is an inherent risk, but I certainly don't think it's the risk that we were talking about 18 months ago for sure. So there you go. In that vein, given that there was not a lot of new and improved COVID discussions, we thought, as we had promised, that we wanted to make this time useful and engaging and educational and beneficial. So we wanted to kind of work in how we do business along with the COVID updates. So we do have some other topics, largely as we're getting into this end of the year, how we're going to kind of pivot and kind of move into next year of kind of our normal course of business for value-based care. So Renee, Jana, LJ, myself each kind of have a litany of things that we're going to go through very briefly. And then, of course, as always, we'll open it up for questions. And if people have things that they would like to stump the audience, if we don't know the answer, we'll poll the audience and see what everyone else knows.
Do you want to address that one question in the chat, though, Chad, before we move on?
Let me see if I can. Where are we with vaccines? We have vaccines and both boosters. Will we be offered another vaccine booster? So let me see if I can understand and answer the question. So if you have been boosted and now the bivalent booster is available, and the question is, can I get the booster? The answer is generically yes. The general answer is that probably, if the initial word that came out is if you were 2 months from your last booster or 3 months from your last COVID infection, that you probably should consider getting the bivalent booster at this time. It's even a little bit murkier than that. There are some elements that are saying you don't even need to wait that long. It's probably okay. As we had talked about on our last call, there is this whole immunogenic drift or immunogenicity of the vaccines, and should you wait a little bit longer to decrease the risk of kind of less effectiveness of the vaccines by packing them in too quick. But I would say for most of the folks on this call, I think most of us are probably at least 4 to 6 months from our last booster. So in that case, I think you have to have both boosters for getting the bivalent. No. And in fact, if you're going to get a booster now, I would get the bivalent. There's no reason not to. It would be inclusive of everything you got in the prior booster and the newer strain. So if you're going to get a booster, you get the bivalent. But if you are, as I think most of us are, at least 4 to 6 months from our last booster, and you have not had COVID, then I think you could make a compelling argument that you should go ahead and get your booster, especially if you're planning for holiday plans around friends and family, and you kind of expect Uncle Ted is going to come in and give you COVID it's probably a good time to get your booster now so that yours got a pretty good immunogenic response by the time Uncle Ted brings the turkey. Aside from that, if you have had COVID within the last 90 days, and I'm saying you, this obviously is applicable to our patients. If we've had COVID in the last 90 days, you have a pretty good level of protection, and there may be reason to delay getting the booster until after that 90-day window, just to decrease the likelihood of that immunogenicity effect of the booster, just from a kind of boring immunogenic or immunology kind of standpoint. The final point, what should we do and or recommend about timing of flu vaccine and the bivalent booster? The balance of thought is that it's fine to give both at the same time. And in fact, if you think the person is a flight risk and may not come back, you probably should give both at the same time. And the relative decrease in effectiveness likely should be small. From the part of immunology that I fell asleep in, and I'm probably going to fall asleep trying to say it now, in a perfect world, you probably should spread the vaccines by at least 2 and as much as 4 weeks to get the maximum immunogenic response of both. However, the evidence behind that from a true functional day-to-day benefit may not be as great as the textbook would say it should be. So I think the moral of the story is, if someone's coming in and, mom's got 3 kids and she's a single mom and she's, there to get her vaccine and maybe get the kids' vaccine, because as Dr. Cook pointed out, the bivalent booster was approved today. So the kids could get the boost now themselves. If mom's going to take off another day from work to come in and get everybody boosted and get their flu shots, probably the better part of valor just to give everybody both now, if they're willing. So take that for what it's worth. That is not the CDC or Dr. Fauci speaking. That is just me, and that's probably worth about as much as something that you read on a gas station bathroom stall. So, all right. I think we have run and that just offended everybody. See, I just lost the entire audience talking about gas station bathrooms. So now I will turn it over to Renee. So we're going to talk a little bit about our 22 reward plan. And so I will pass the baton to Renee.
Thanks, Chad. I'm actually going to mess with our agenda a little bit and ask for Willie to share his news that he sent me an email about earlier today, because I think it's a nice segue into what I have to talk about, actually. So, and it's important information. I want to make sure it gets out before we lose any of our audience. So go ahead, Willie.
So just to let you know, we put up the maintenance page on the Arcadia site probably about a half hour ago. There are some configuration issues that caused the site to look like there was a PHI issue. If anybody would have went into the site, logged into the site, that first landing page you go to would have seen all the widgets for all the active patient lists for all of the practices. That was not a PHI issue. You could only see the patients that you're responsible for, but the visual was very, very bad. So I decided to throw up that maintenance page before that to get that fixed. Hopefully that's fixed within the next hour or so, but the visual was just bad, but no PHI was issues were there. So just want to let you know.
Thanks, Willie. We'll do our usual follow-up email after this, later today, and we'll share the status of where the fix stands by the time that email goes out. Okay. So that's I wanted Willie to bring that up first because it's kind of a natural segue into my next topic, which is our 2022 reward plan, which you've been hearing a lot about. You might wonder how Arcadia dysfunction and the reward plan have anything to do with one another, but if you've been paying attention, you'll know that it does. So our 2022 reward plan was created with the desire for our providers to be better aligned with their incentives, to be better aligned with the ways in which AHP earns gain sharing. So we've been messaging to you that for the 2022 performance year, you're going to be on the hook not only for incentives based on your quality measure performance, but also in some certain facets of cost performance and citizenship. And then also along with that messaging was that you're going to have insight into this performance by using our new provider engagement report, which would be you would have access to, that would give every provider that's part of the reward plan visibility into how are they doing for their quality measures, how are they doing in these cost performance areas, and how are they doing in their citizenship. Well, here we are in October, mid-October of 2022, and we have not rolled out the provider engagement report to the degree that we had hoped. There are some Arcadia data issues. We feel that the data, even post upgrade, is unreliable. So you haven't had any real insight into your actual quality performance. And our window for achieving improvement of performance that you're seeing, it's closing. It's 12/31/22 is the end of the performance year, and here we are in October. So we have decided, AHP leadership has agreed that, due to our data issues, due to the significant delays in the PER rollout that have prevented you from really, having visibility into your performance and the time to address any shortfalls in that performance, we have decided that the 2022 PCP reward plan, which will be paid out in around September of 2023, that we're going to hold our physicians really harmless for quality and cost and citizenship performance. We're going to, by and large, pay out the incentive for what we have available for distribution for the 2022 reward plan on an equal basis to the providers that are on our contracts for 2022. We just don't think it's fair to pay it out differentially based on performance for which you've not had sufficient opportunity to understand, to view, and to correct and close gaps. So we'll be sharing greater detail of what this means as far as on what basis the award will be paid out with those PCPs that are contract par and that are part of that 2022 PCP reward plan. But so my real purpose for speaking with you today is just to make you aware that because we are still moving ahead with the PER, we are training. That's really my next topic I'll transition to. And we're sharing with you this messaging that this is your tool and this is how you're going to be able to manage your performance. And while at the same time still dealing with some Arcadia issues, we just feel it's important for you to know that for 2022, providers are going to be held harmless on their quality and cost performance. So more to come for those providers that are contract par. We'll be sharing more details with you and with your practice administrators. But for right now, that's the message that I wanted to share with you. And all that said, I'll go into my next agenda item, PER, the provider engagement report. We are still rolling it out, and practices that are eligible to access the provider engagement report have received their user spreadsheets, either sent by myself or by Jana. And these user spreadsheets, what we're asking for from you, first of all, we're sending it out pre-populated. We're sending it out pre-populated with the names of the folks in the practice who we think are the most likely ones that you would want to have access to the PER. Your practice administrator. If you're a practice that is owned by one physician and the rest are employed, the physician owner is listed. Or if you have a quality person, the quality person. All that said, when we send this spreadsheet out to you, we do include that the note that feel free to add other users. So when that spreadsheet comes out to you, you're not limited to just giving access to the PER to the people listed. Feel free to add whomever else that you like. All we're asking you to do is to take a look at the information that we've populated in there. Make sure we've got the NPI correct, the first and last name. If the user has a middle initial, we're asking you to share it. We're asking you to verify that the email address that we have for your individuals is correct. And then there's some additional information that's really important as well, because the PER is the platform for the PER are URMC resources, URMC servers. The access does involve URMC credentials. So we're asking you the question of, is this person a former URMC employee? Yes or no? And if they are a past URMC employee, their name at the time of employment, if it's different, maybe there's a maiden name situation, and for that to be shared. We're also asking you to answer yes or no to, is this individual a URMC ePartner user? And then finally, we are asking you to confirm the access level. We've put in an access level that we think is appropriate. For example, the practice manager should probably be able to see the entire practice's performance. So we've selected location for that individual. And then a provider in the practice, perhaps we just put provider access, which means that provider can only see their own performance in the PER. So we're asking you to verify what we've shared or change it if you'd like different access levels. All of this information is contained in the email that we've sent you, and the spreadsheet itself on the first tab has an explanation of what we're looking for in each field. So I just wanted to get, there's been a lot of questions about this process and the spreadsheet. So I just wanted to just run through that with you really quickly. And of course, myself or Jane are available for any questions you may have about that. We do have some PER training that is up and ready to go. We did our first large group training just on Monday. And I'll share my screen really quickly to show you where you can find the schedule of large group PER trainings. So if you're on our website, you're going to go up to Partner Resources, and you can select the calendar of events. And then this is pretty cool too. You can search for events, and if you just enter PER training, you'll get the whole list of what are our remaining dates for large group PER training. And when you click in there, you'll see the Zoom link and the date and the time. So folks are welcome to just log in and attend those. We don't need an RSVP. We are recording the sessions, and we're going to be uploading it to our YouTube channel. So if by any chance you were to miss every large group PER training, we will have recordings available for you to view. And we're also happy to, and I imagine we'll also be conducting original trainings. You do not need to have completed your spreadsheet and have your guest account all done and hemmed, all ready to go in order to attend this training. It's helpful, I think, if you do have all your spreadsheet return and the guest account process finished and you're able to access the PER in advance of the training, right? Look around, poke around at the data, and then you'll come to the training with better contextual understanding and maybe lead to better questions, but it's still not necessary. You're absolutely welcome to attend and attend as many as you like. So that was what I just wanted to share with you relative to the PER. Still rolling it out. Really hopeful that for 2023 performance year, that's going to be a really useful tool with a background with Arcadia data in the background working well and data in which we have confidence. So we look forward to seeing you at some of these PER trainings. And then if folks don't mind, I'm just going to go right into the final thing I wanted to talk about, if that's okay with you, Chad. I wanted to make our audience aware, and I will share this information in our follow-up email as well, that there is going to be the Department of Imaging, Your Medicine's Department of Imaging is conducting an event. The chair of imaging, Dr. Harvey, is hosting a meeting next week, October 18th. And I thought would be of interest to this audience was addressing imaging backlogs. We understand that the access into imaging has been highly problematic, and I wanted to make folks aware of this opportunity to hear what the department has to say, and ask questions about the process for getting in patients and what the forecast looks like for improvements in that regard. So no need to be anxiously scribbling this information. I'll be sending this out in the follow-up email later today, but I wanted to make folks aware of this opportunity to hear from the Department of Imaging. So that is all that I had to share. Happy to answer any questions in the chat or otherwise, but then I'm ready to turn over to LJ if you're ready to go.
Sure. Thanks, Renee. I just have a couple of things for the team. I wanted to let you all know that we are re-engaging around our LARC, long-acting reversible contraception initiative this year. And realizing that the pandemic offered some sort of a bizarre blip for all of us. It's been quite a while since most of us have done any reproductive health counseling training, looking at the latest evidence-based resources that are available. And so our focus for this fall is really to provide an opportunity in a 1 hour and 15-minute Zoom session that will feature Dr. Rachel Phelps, who's a local expert on reproductive health. And essentially that the talk will be about increasing access to LARC for your adolescent and adult patients through evidence-based counseling and practices. So this is not a soup to nuts, everything there is in contraceptives available. This is really going to focus in on the long-acting reversible contraception that is available, but also really the approach to that. So there certainly is a role for starting someone on shorter acting contraception while perhaps waiting for placement. Rachel does a fantastic job with this lecture. I know, having been in practice for, 20 plus years, when I attended one of her talks, it totally revolutionized the way I approach the conversation with my adolescent patients and with families. So I really strongly encourage folks to attend. We're going to hold the session twice. The exact same session will be held twice. The first one, you don't have to write this down. We're going to send out an invite, make sure you all have this, but the first one will be in November, November 17th, which is a Thursday. We're going to run these from 5:30 to 6:45 with the hope of catching you at the end of your workday, but not interrupting and taking too much from family time. The second exact same session will be on Wednesday, December 7th, same time, 5:30 to 6:45. Just to highlight for any of you who are on our pediatric advisory council, we are going to cancel that meeting and put this meeting in its place because we want to prioritize this training for all of our providers. You will be getting credit on the PER, just referring back to what Renee has said. This is what we're looking at, is what's really important. I don't need to go into a long speech about why, but in our current environment, every single patient we care for should have the opportunity for the most up-to-date, thoughtful information to help them make the best choices for themselves. And so that's why we feel this is so critically important. So you will receive information, have an opportunity to RSVP on this, but we look forward to that session. The other thing I just wanted to say, I am taking a giant step backwards into COVID land for a moment without a whole lot to say, but I wanted to re-up what Steve Cook had put in the chat and Chad had mentioned as a reminder to all of our providers who care for children that the bivalent booster for kids is now approved for 2 months following your primary series. 2 months after the primary series, the bivalent booster can be given. And this goes down to age 6 for Moderna and down to age 5 years for Pfizer. So I just wanted to clarify that for folks. And then the last thing is, last time we talked and talked about a number of things in terms of COVID guidance and protocols that were either being archived or retired. We left out there sort of hanging and waiting the whole return to play algorithm because we had been notified that the AHP would be updating their guidance, which they did on September 9th. For those of you who may not have noticed it, it is on their website. Actually, I have to be honest with you, the changes were so minimal that it really doesn't provide any substantive change to the previously published guidance that we did through the Finger Lakes and Western New York task force. So what we did is went and looked at this and did highlight and want to highlight to all of you that we still think that the self-assessment form still makes sense. It allows for providers and for parents and for schools if needed, just to see if a child, by any chance, a child or an adolescent, falls out of that asymptomatic or very mildly symptomatic category in which they really should have some type of assessment by their PCP. That's really the way that we're looking at this. We know fully that the implementation of this or following of this guidance at a school level is all over the board. So this is really about some guidance for you, for your families and your patients who do have COVID and where they should be coming in at least for a PCP assessment. Of note though, if the answer to all of those questions on that assessment form is a big no, then those kids do not need to see a PCP for evaluation unless you deem it otherwise for something different. And that youth or student or athlete can return to sports and physical activity as per the rest of the guidelines. So just trying to make that piece a little bit clearer. This information will be shared out across our networks. It'll be shared throughout Rochester Regional's networks, and then we're also sharing it out through the schools. So same algorithm, it just says reviewed on, now an October date in 2022. I'd hope we'd have something more substantive, but that is what we have. Last thing to note though, from our pediatric cardiology team at Golisano Children's Hospital, they have not encountered any recent cases of myocarditis due to COVID-19 infection. So I wanted you to have that piece of clinical information as you're taking care of your patients. And I think that's it for me. Chad, back to you.
One question in the chat for you, LJ, are the LARC questions recommended even for people who's previously had the training?
Yes. Everything changes, right? And so updated guidance is valuable. There's changes to some of the methods. There's changes to the data and information that we have. So we are recommending anyone who it's been more than 2 years since they did their LARC training that they attend this reproductive health talk. Again, this is not training for you to place LARC in your office. That's a whole different thing. And for providers who are interested in doing that, who have not already trained, we can offer resources for that. This is really about your knowledge base and the conversation that you have with your patients. The only other thing I will say is, this talk, I'll give a touch of a preview. Our adolescent pregnancy rates, unintended rates, have really dropped dramatically in our area, particularly in Monroe County, over the last 6 years. And much of that likely has to do with the use of an adoption of long-acting reversible contraception. But the rates of unintended pregnancy for adults is still very, very high, and your risks for both the baby and for the pregnant person in that space, are high as well. So this talk will be geared not only about adolescents, but also for providers who care for adults. So it's a little different spin and more information than I think you would have received from a traditional LARC talk.
Perfect. There we go. So I am going to round things out before we get into any final questions. One of the most highly anticipated events of the year, like Oscars, Nobel Prizes, AHP clinical grand rounds, coming to a theater near you next October 19th, which is what, Wednesday? Should know my days by now, next Wednesday, 5:30 to 7. It's going to be virtual. We actually have a huge celebrity guest that's going to be emceeing. So you definitely don't want to miss it. It's not a celebrity guest, it's me. So just go ahead and dissuade that from your memory at all. If you're not watching the camera, it just makes you want to come. That's all the better. So what we decided to do this time, because we really wanted to appeal to the broad audience, is to basically we'll start together. We'll go through some kind of general housekeeping kind of stuff. A lot of it's going to be very redundant to what Renee just presented. So it's just going to be a little bit of piggybacking on Renee. And then we're going to break out. And we're going to have 2 rooms. There's going to be the maternal child health breakout group and the adult health breakout group. Now, if you're trying to sit there, scratch your head and say, boy, I can't decide which group I feel like I belong to the most at that day. Number one, we are not going to restrict you. If you're purely an internal medicine provider, I'm going to go out on a limb and say you probably don't want or need to be in the maternal child breakout room. However, we are equal opportunity, so we're not going to keep you from going wherever you may want to go. However, for those who really feel like they need both, we will be recording it so you can watch the other breakout room at your leisure if you so choose. There are 3 topics, so it's kind of a multiple small feedings kind of format. For the maternal child health breakout room, I'm reading these off, so I'm looking off camera like I'm looking at a cue card. Population health focus for perinatal care, interprofessional care management model led by Ava Pressman, Jenna DeSimone, and Ellen Polshik. That is topic 1. Topic 2 is advancing health equity for the rural population through lactation care management by Katie Whiteman. And then topic 3 is current and future state of maternal child health with Jeff Kazarowski. So that will be the breakout group 1. Breakout group 2, which is the adult health breakout room. We have Dr. Mark Levstick from GI talking about liver disease testing, specifically around fatty liver and referral best practices. Topic 2 is lipid management and primary care and some of the new medical management and specifically guidance for patients who have testing on non-invasive testing, such as coronary calcium scoring, and when they should be tested or treated and what the appropriate treatment thresholds will be. That's Dr. Jason Pecos, Chief of Cardiology at Highland Cardiology. And then the final topic is guidelines for evaluation and diagnosis of pulmonary nodules, when to follow up, especially important in our CT-guided lung cancer screening program. And so that's going to be led by Dr. Mike Mead and Dr. Christina Doney from Pulmonary Critical Care. So 2 breakout sessions, each with 3 small topics. So hopefully it'll be high yield, short time. So in an hour and a half, you'll get everything you wanted to know, and you will have attended one of the most highly anticipated events of the season. So I highly, highly, highly encourage you to plan to attend if you haven't already. And I can't sell that anymore. So there you go. So with that, I think we have covered our agenda for today. I don't see any lingering questions in the chat room, so we'll give everybody a chance to speak now or forever hold your peace. And otherwise, give you 5 minutes of your life back. All right, I don't see mute buttons getting clicked at a feverish pace. All right, everybody, have a lovely month. We will see you next time, and we will see you all next week at Clinical Grand Rounds. Thanks so much.
Bye now.
Everybody.
Take care, guys.